I'm Courtney Volker, and I've taken a serpiginous route to get here and land here in Los Angeles. I grew up in Oregon. I was born in Colorado. I went over to the East Coast for undergrad and medical school. And then I stepped out of my training of medicine to go across the pond to England to do a PhD in developmental neurobiology. I stepped back into my surgical training, landed in St. Louis at Washington University Barnes-Jewish, one of the largest clinical centers in the country. And then I came over here to Los Angeles, where I did my fellowship training in lateral skull-base surgery and neuro-otology at the world-famous House Ear Clinic. And I was the division director at USC for 6 years and was recruited here by Dr. Griffiths and the PNI group to really build a lateral skull-based program, which has really been missing as a little Lego piece in the vision of PNI and the Providence healthcare system in general in Los Angeles. So my area is the ear all the way to the skull base, and I interface with the neurosurgeons regularly on skull-based tumors from a lateral approach. I interface with Dr. Walgama when he has very complicated head and neck cancers involving the temporal bone. I interface with Dr. Kochar when we're operating around the facial nerve, and general ENTs when they have trouble with hearing and balance. So I feel very blessed to be able to have a very collaborative career, and in my day get to interact with really smart and inspiring people. So we really have an opportunity here in Southern California. This is an area where, as Dr. Griffiths had mentioned, my patient population is really bottlenecked in the academic centers, and really they're not getting efficient and quality care for disease processes that really need acute attention. So our centers where this is happening is UCLA, USC, which I'm intimately have knowledge of since I was there for a long time, the House Ear Clinic, which is going through a lot of changes right now, and Cedars-Sinai. So this is not reaching the patients for being the second largest population in the country. So we have a real opportunity here at St. John's in the greater metropolitan Providence area. So just very briefly, the ear houses both the hearing apparatus and the cochlea, and the vestibular apparatus is the other side of the inner ear, the semicircular canals and the otolith organs that tell a human being where they are in space. So this is where I live in my day. And we'll just talk about hearing loss mostly today, and we'll really focus on sensory neural hearing loss today. My other side of hearing is conductive issues, which also have surgery, but we'll focus on sensory neural components. So 30% of it, this is a huge problem in the world that really is not being addressed. As Dr. Griffiths said, you know, only 3 cents to the dollar for blindness. Now, everything should be funded, but hearing is really underfunded and is really affecting a lot of people, where people are silently suffering in our community. 30% of adults greater than 50 have hearing loss, 55% adults greater than 80. The prevalence doubles each decade of life. It's the third leading chronic health condition among aging adults, and 580 million people worldwide have some form of hearing loss. This can affect little babies. This is my son, Leo. Thank goodness he passed with flying colors his hearing test in the hospital, but many children don't. And that's where Becky Lewis and I jump in there and try to intervene very quickly for cochlear implantation. So identifying these children, getting them through the process very quickly is where we specialize. And here the Providence has high population birthing centers where we hope to get in there and really well train the screening folks and get those children identified. And then all the way to our grandparents and our elderly in our population. That's the range, but other things can affect hearing. infections, chemotherapies, meningitis, drug side effects. I'm seeing COVID infections, COVID vaccine affecting hearing loss, trauma and fractures, as Dr. Kochar had mentioned, the little boy as well. I see these patients coming through as well. A new area of research is brain health. So we're learning that hearing and balance is really vital to keep the brain healthy. And this is a mission of PNI in general. And I fit under that umbrella, Becky Lewis and I both, in understanding how hearing and balance affects the brain. So that people with hearing loss have depression, anxiety, social isolation, inability to work, losing their jobs, loss of independence, balance impairments, falling, breaking hips, comorbidities, cognitive decline and dementia is a huge one, cardiovascular disease, diabetes, and one paper even linked hearing loss with mortality. So this affects the person in general and affects many different body systems. This is very important, and it's how I've changed in counseling my patients. Back in the day, we used to say, well, if the patient's not complaining, don't get a hearing test. And if we get a hearing test and they have a little hearing loss, until they complain, then you can mention hearing aids. Well, I've really changed my practice because there are studies that have come out where we test people's cognition at time 0. We then fit them with hearing aids or cochlear implants for as little as 6 months, and we retest their cognition, and we can see that their cognitive scores go up. So when we intervene with hearing loss, this can really change the brain and change the neuroplasticity and keep the brain healthy. So yes, hearing improvement can improve brain health. It decreases social isolation, loneliness, depression, anxiety. It interacts with all the neural mechanisms. And so how do we do that? Well, hearing aids are a source of natural auditory pathway. They stimulate and amplify our natural pathways. These are some of the older historical ways that we used to do that. Thank goodness we've shrunk things a little bit. I always find them interesting to look at and the creativity involved there. But now we're on to the second phase of cochlear implantation. This is really creating, it is our only brain sensory interface we have in medicine. So it's the only device we can implant in a person that can restore a sense. We can't do it quite yet in blindness. We can't do it quite yet in paralysis, but we can do it in hearing. And if you implant a child before the age of 3, actually, we try to do it as early as possible. You can, they can develop normal speech, they can mainstream in school, they can understand on the telephone. So this is quite something. So when do we identify those patients? This is what a cochlear implant looks like. This is sort of an older model, but they're getting smaller and smaller all the time. The electrode actually goes into the cochlea, bypasses the middle ear space, and stimulates the auditory nerve directly. Now we're getting smaller and smaller external pieces, so it's just worn under the hair, and people don't even know that at a person that they have an implant. This is the take-home slide. We are doing terribly in helping folks with hearing loss. So these statistics are awful. So less than 15% of adults who benefit from hearing aids actually use them. 5 to 7% of adults in the United States who would benefit from a cochlear implant actually get implanted. So we have a lot of work to do. I'm going to be very tired. But also, the delay in treatment going around doctor to doctor and doctor to doctor is 7 to 10 years, if you think about that. That's really horrible. And now that we have the connection with brain health, think about all those central neurons that are atrophying and not getting stimulated. This is another shocking slide. So only 3,500 adults in the latest data receive a cochlear implant in the United States. So they're doing better in Europe than we are in the United States. And I personally feel that patients are getting bottlenecked at these academic centers, and we need to really bring this technology, surgical skill set, and programming after the implant, which is what Dr. Lewis does, out into the masses of the people that need this. 350 adults in the greater Los Angeles area get implanted at these major centers. So this is horrible, and we can do better. And this is why I was recruited here, to make an impact in the Providence system. We have a great team to start working with, led by Greg Frazier. He has an excellent group of audiologists who are well established in multiple areas within the greater Los Angeles community. This takes years to build, and we're walking right into what he's already built. He serves numerous volume of patients, and he has 3 audiologists who already have some training in cochlear implantation. So we have great building blocks to work with here. I recruited Becky Lewis from USC. I'm so glad she said yes, and she joined me. She is a vital piece of the puzzle. She is one of the only cochlear implant audiologists who has both pediatric and adult experience. Usually that is in 2 different human beings. She has it all. She's extremely skilled and is nationally renowned, and she's with us, and she's going to really help me build this program. So the youngest patient I've implanted is 3 months old. The FDA finally came down from 1 year to 9 months, but we are implanting younger and younger and younger. The oldest patient I've implanted is 102. So I really look at the patient, not the age, and see how they can benefit from this amazing technology. It takes a team. This is a team approach. It's a team sport, like Dr. Griffiths had mentioned. And I'm really happy that we really do have all of the elements to make that possible. The surgery is pretty straightforward. If the patient's healthy enough, this can be done in an outpatient setting. Some of my sicker kids I take to CHLA, where I was the director of cochlear implantation there. And if they're older and sicker with comorbidities, we can do it right here in St. John's Hospital. So it really depends on the comorbidity of the patient. The programming, this is where Becky Lewis comes in. It's really a custom-made program developed for the patient. Younger patients, their brain just clicks right on. Older patients with some already cognitive issues need some extra tender love and care. We're going to be forming support groups like Dr. Kochar mentioned, and we're learning from COVID that the virtual world can really help with that. Things are connecting to our iPhones to help people hear. And the second part of my life is acoustic neuromas and lateral skull-base tumors. This is where I interface with the neurosurgeons. I've been one of the first in the country to place a cochlear implant when I remove the tumor in a patient that doesn't have hearing. These patients are doing great in an area where we can really expand our knowledge. I work with a great neurosurgery team here, Dr. Garni Barkadarian at St. John's and Dr. Wally Silva Kumar at Little Company of Mary, and we've already had very good outcomes in our surgeries. This is just a little grouping of some patients I've helped. The center photo is an LAPD officer that had a injury to his acoustic nerve in his inner ear. He did great with his cochlear implant. And this little guy over here is one of my patients that I did bilateral implants on when he was a baby. He is amazing. He's an honor student. He's mainstreamed. And he wants to be a cochlear implant surgeon. And I don't know of one in the world who has implants who's an implant surgeon. So he showed up to my office like that one day for his checkup, and I almost cried. So he's great. And this was another father who got a tattoo so that his daughter didn't feel alone in her journey.